Welcome to our 100th webinar, and the topic today are the 2017 threats and safety, why hospitals should fly, mortality reviews, harm from omission, medtech, and healthcare violence. And I'm Charles Denham, and I'll be the MC today, and we'll move very quickly through the topics so we can cover them. I'm on slide 3 for those that have the slides, and those that don't. If you have an audio problem and aren't hearing properly or correctly, please go ahead and turn the volume up on your computer, and then if that doesn't work, click on the participants icon, and click on the phone with the question mark icon, and we'll give you a landline to help you. For those of you that don't have the slides, go to www.safetyleaders.org. In the upper right-hand quadrant, you'll see upcoming events. Click on that, and then you click on the hyperlink. For those that are watching, and today there are a lot of scheduled events that are competing with this one, so many of our attendees will be watching the on-demand version, and please feel free to go to www.safetyleaders.org, click on the link, and we'll post other resources on the web page that is on slide 6. Our social media coordinates are on slide 7, and our purpose statement that we will protect and enrich the lives of the patients and caregivers is our purpose. Our mission is to save lives, save money, and create value in the communities we serve. And our disclosure statement is that we will not be covering any product or technology with any financial relationships whatsoever, and it's a 2-page disclosure that you'll find on page 9 and 10. I'm going to introduce each of the speakers, but because we have a full agenda today, and those of you that are on demand, we'll move very quickly, and you'll be able to see their pictures on the website as well. However, we have John Nance, who will be speaking first, Jeanne Huddleston on mortality reviews. Liana Orsolini will follow up and talk about their journey. Dr. Greg Boats and Chief Bill Adcox from Houston, MD Anderson, will talk about medtech and workplace violence and tie those together. And we have a wonderful reactor panel of Arlene Salamandra, Hillary Schmidt, one of our global leaders in CME, Jennifer Dingman, Dan Ford, all great patient safety champions and advocates, and Becky Martins, and we're so honored to have them here for this webinar. So I'll start off with Arlene giving us the voice of the patient and family. Arlene, can you start us off?
Well, first of all, I want to thank everyone for being here on the webinar, and to be the 100th webinar is such an honor. So I want to thank Chuck for giving patients, especially patients, and caring healthcare professionals this opportunity to work in partnership for safer care and to learn from others, all our experiences, because we're all very important to the evaluation and quotation or whatever. But back to you, Chuck. Thank you so much.
Thank you, Arlene. And I'm going to move very briskly through a news update and then our national survey results. But I just wanted to address the fact that, our average Net Promoter Score is over 91% now, and we had a wonderful response in the last 2 to 3 months while we've been covering the mortality reviews. This is just the one, for those of you that are logging on for the first time or on demand later, this is our 100th sequential monthly webinar. And this slide really on slide 15 is to thank our current speakers, but all of you that are speakers that are listening for all of the great work you've done. This is 100 months in a row, all free webinars, all donated time by the speakers, no financial sponsors whatsoever other than us putting them on. We've delivered over 50,000 live learner line hours, and multiple people are on lines live. And we've estimated that over 180,000 live learner hours of continuing education content. And since 2012, we've been measuring our Net Promoter Score, and we're so honored that we've had such a strong user response of a 91% Net Promoter Score. Just FYI for the audience, We've had many speakers from CDC, HHS, HRSA, ARC, Joint Commission, and researchers undertaking performance improvement activities. And so many of the surveys we've done have fed into things that CDC, HHS, HRSA, ARC, Joint Commission, and researchers have done. We've had a number of speakers from those organizations, and I can't name them all. There's so many. And the voice of the patient is so critical. The folks that we'll have on today for our reactor panel are fabulous patient advocates and really voice the patient in each and every webinar, not only as those that introduce, but also as reactors. So what's in the news? Two quick items, and I'm watching our time at 5 minutes after the hour. Yesterday, ECRI released the top 10 patient safety concerns. What we put in red are the topics that we've been hammering away at in 2016, and so we have a survey that we'll survey you as an audience here shortly and ask you, do you want us to address ECRI concerns? We've done it every year, and the topics you want us to address, but you can see EHRs, patient deterioration, opioid overdose, misdiagnosis and test result issues, and the management of oral anticoagulants, and that has been a hot topic every year, and there's so much going on. The second piece of news that I needed to really address here is the court in Florida has ruled that the PSO, Patient Safety Organization's patient safety work product is unprotected from litigation discovery. So we're going to have to watch this in the news, but this was wonderful legislation that provided a protection from discovery, but it had to go through the courts. And I think this is something that you're really going to have to keep watching, and many of us are submitting, or many of you are submitting to the PSOs. Now, Dr. Huddleston's reviews, and she's done a number of webinars with us, we polled you as an audience and asked, are you interested on more detail from on mortality reviews, even though we've already covered it in multiple webinars? And just an amazing 66% of you gave it a 10, 93% agreed, and 81% strongly agreed. I'm not going to go through the topics that we gave you for free text entry, but we're listening to you, and we will address those in 2017. They're on slides 20 and 21 because I want to give our speakers time, and you can go back and review the topics. We ask, would your hospital be interested in participating in a 100-case safety learning system collaborative? A lesser number, but still 53% agreed, and I know Jeanne is still recruiting folks to such a program. Then we addressed this issue of performance improvement topics of omission, and we asked the question, are you interested in a deep dive webinar on errors of omission? This was your September result, and that's why we followed up with surveys on this topic and webinars, and it appears that you still really want that to be strongly covered. We asked you if you wanted to hear from people that started with their mortality reviews from scratch. Again, 57% of you gave it a 10, and 84% agreed, and 71% strongly agreed. So that's why we will continue to focus on these topics as we go forward. Then we also polled you on bystander care and the topic that Dr. Boats will cover, and the report by Dr. Don Berwick focusing on bystander care for trauma, and the other National Academy of Sciences report on translational research, which Dr. Boats will address for cardiac arrest. And we asked you in the last webinar last month, do you want more information on preparing non-clinical staff? These are your non-clinical folks for emergencies and bystander care, and we see 65% agreed, 31% of you gave it a 10, which is, these are pretty high numbers for us. Don't be, the mortality review numbers are just off the charts, but we see a very strong response, which we will follow up on. And on slide number 29, again, I'm not going to read the slide for you, but go back and look at the bystander care issues. And then the final survey question that we had was regarding sham HR review and this enormous fear that caregivers have at the front line regarding when something goes bad, them getting hung. and we asked the question, do you want more on sham human resources review and how we can take the high road, and what are the best practices that we can take to reduce fear of employees on retaliation after adverse events? And again, 64% agreed, 31% of you gave it a 10. So we will follow up with that. And we had free text entry, and we really appreciate the free text entry because that's how we design the webinars to meet your needs. And you can see those topics on slide 32. So with that quick run through, and sorry for moving quickly, but because we have such great speakers, I just want to move on to John Nance, who's giving a major keynote today, but wanted to be involved in our 100th webinar. And John is so well known to us. He's a best-selling author and pilot. He was a captain with Alaskan Airlines. He is the safety journalist and leader and expert commentator for the ABC. He has a law degree from SMU and has written bestsellers both in nonfiction and in fiction, in the fiction areas. Most importantly, he's probably one of our most articulate champions of patient safety who routinely speaks truth to power, and it's such an honor to have John on. Go ahead, Kyle, and roll the tape of John for today. We've asked John to address what we really need to look forward to in 2017. His two great books that so many of us have read, have really been inspirational. They've given us guidance and leadership. And so we've asked John today to do two things. One is to kind of build on those stories and tell us what we really need to look forward to in 2017. And the second part of his presentation, we're going to build on what he had shared with us previously about medical identity, theft, harm, breach, and those issues, as well as professional identity harm, and how the red cover reports that he's envisioned could have real impact to help us in leadership. John, the first question is, tell us, what should we look forward to in 2017?
Well, you remember the old Chinese curse, may you live in interesting times. I'm afraid we're in an exponential situation now, especially American medicine. We're being plunged back into chaos, even more of it. We don't know what's going to happen with the Affordable Care Act. We don't know a lot of things about the uncertainty of governmental involvement and the reimbursement chaos that's inevitably going to follow. And unfortunately, for a while at least, a hobbled CMS. And CMS has been leading a lot of the charges. But even worse is going to be the more than likely temporary reduction of government oversight and the predictable rise of criminal acts in a lot of different ways. Criminal acts not only in taking money that shouldn't be taken from the public trough, and also things in way of criminal acts in cybercrime. And there's a lot of that to be worried about, including taking medical records and stealing identities. You remember the old adage, when the cat's away, the mice will play. And the mice are going to be having quite a time here in the next year or two. Cybercrime is one of these new areas that we've talked about in the past, and it is incredibly important that the medical community begin to get a real understanding of it, because it's not just stealing medical identities from patients and interdicting medical records. It also has to do with stealing the identity and the efficacy of medical professionals, including invasion of the process of putting out papers and the journals and what can be trusted and what can't be. And I'm afraid we've got a good chance in the chaos that's about to ensue to see a lot of this. So where we were able in the past, I think, to have a fairly good feel for who was watching the shop, not only internally in the IT department of a particular hospital and so on, but externally too. Now the responsibility falls on everybody's shoulders to be much, much more vigilant and to be much more knowledgeable of what these potential threats are, especially when a certain amount of the oversight is removed from governmental levels. So what's left, by the way, guarding American medicine is going to be all the participants, the doctors, the nurses, the administrators, all of us. And patient safety, of course, in my mind, is most paramount. I've been fighting this battle for nearly 25 years, bringing across lessons from other industries, such as aviation, although that's not the only one. And now we are just about at a turning point in understanding a lot of things. As a matter of fact, you're going to hear in a little while from the experiences of Mayo mistakes are made to how could we have done it better, and looking at medical situations on the basis of every patient, asking the question, what could we have done better? And that takes into account not just catastrophes, but also intermediate situations where improvement is possible. And I think that is opening the door to an awful lot of improvement that we can actually continue without any abatement by simply taking care of some of the basics that we now understand. There have been major breakthroughs, and I think this is fair to say, major breakthroughs in understanding where our problems come from when we do have medical misadventures, whether we want to call them sentinel events, near sentinels, whatever, whenever we're not doing the job to the extent that we should be. And one of the things that I have been maintaining for some time, and I really stand by this, and I've only had a few people kind of get upset about it, but I think it's really worth thinking about. The traditional methodology, if you will, for every doctor, for every nurse, for every hospital, healthcare center, medical professional, anyone, is to say, I'm going to do my best. Certainly for every physician, it's I promise to do the best to the best extent of my training and my experience, etc. Folks, that's no longer enough. That just won't cut it anymore. And the reason why is because medicine is too complex, far too complex. It is no longer a solo sport if it ever was. Certainly now we've got to operate in teams. We have to operate on the idea that medical application of anything is so important and also so complex that we can't do it alone. And to that extent, we've got to reform that covenant. And the covenant has to be now from every doctor, every nurse, every medical professional, I promise to give you the best that medical science can provide. It goes without saying that I promise to give you the best I can provide, but you've got to go beyond that. It has to be the best medical science can provide, which is why shifting the emphasis to what could we have done better, even when there was no catastrophe, is very important. I've been asking a question of all my audiences for the last 4 years, approximately, all medical audiences. And I've been asking them this question. Is there anybody in the room who has been up close and personal with a sentinel event or a near sentinel event in which there was no component, no failure in human communication? In other words, has anybody seen one where we had a sentinel event that did not involve, at least as a component, a failure in human communication? I figured about 35 to 40,000 people have heard that question face-to-face over the last 4 years in my experience. And I have had a total of 4 hands raised. One didn't understand the question. When we got that cleared up, her hand went down. The other was an orthopedic surgeon who'd had an appliance break. Neither of us could figure out how that had anything to do with communication. And the other 2 were fairly trivial. But stop and think about that for a second. Look at almost 40,000 professionals saying that we all understand with great clarity that you cannot have a patient safety misadventure of any degree of seriousness without a failure, at least in part, of human communication, not just verbal, but human communication also in terms of what wasn't said, the things that we didn't do, the opportunities that we didn't take, the opportunity to read something incorrectly on the screen, for instance, since we're using computers more and more. This, in other words, is one of the great pieces of low-hanging fruit in patient safety that we're not going to have to back off on. It can be attacked just the same whether we've got monetary problems, whether we've got regulatory problems, whether CMS is at our side or not. And this is something that we've got to push the throttle up on even more. Because if we can have a better, more realistic view of human communication of what goes wrong and be able to anticipate it, we're going to be able to solve at least 50%, maybe more, of the potential for terrible misadventures in medicine as a result of all these things, including nosocomial infections. I mentioned teamwork, and teamwork is also the great new frontier. It's not just a buzzword. One of the things we've got to go back and do is to explain to everybody, to get their, not just buy-in, but to get everybody on board with the philosophy of applying teamwork and checklists and standardization and minimization of variables is so important because we presented it badly over the past 15 to 20 years. We kind of threw open the doors, and an OR, for instance, has said, hey, doc, here's a new procedure. We don't have time to explain it to you. Just do it. Of course, we insulted an awful lot of very great people. We've got to go back now and make sure people understand that a checklist, for instance, or a standardized procedure is not an insult. It's not saying we don't trust you, doc, you need this as a crutch, any more than it was when we put checklists in front of a captain in the airlines and said, hey, it's not that we don't trust you, it's that we know this works. And we're in a team effort to make sure we get our passengers safely to the other side. And for those who want to roll their eyes and say, by the way, I don't want to hear any more aviation analogies, we use the same component, that's human beings. So I think those are important. So the basic thesis here, before I just wrap this up and answer your question about one other thing, which is the red cover reports, the basic thesis is that we have an awful lot that will not need to be retarded in any way, form, or fashion in terms of the effort that we're putting into trying to make changes that we know are substantive with respect to patient safety and quality of service. But we've got to change that ethos. It's not anymore, I'm going to do the best I can. We've got to promise and deliver on doing the best by providing the best that medical science can provide, and that opens up a whole new standard.
Thank you, John. And one of the key issues that you brought forth this last year, and I want to draw our attention of our audience to, sorry guys, to stand by real quick, teams, to own medical identity, cybercrime, and computer crime as it relates to the medical records being contaminated, because this is an enormous problem. We have in 2016, likely one in three of our population have had a breach. 1 in 5 of those have been contaminated by some form of fraud, and 1 in 3 of that group, which is 1 in 45, may lose or may have lose their health care insurance because they could never get it corrected. And the numbers are still, John, pretty close to $14,000 out-of-pocket costs to correct those. So you made a great case for that. Let's shift gears for a sec right now as you conclude your presentation and address the issue of professional identity harm. That is to say that we do know it's very rare that people might steal a professional identity. We've seen that, and we've had to retract articles, and we've addressed that in prior discussions. But, John, address how we could use your concept of the red cover report, which you've covered in prior webinars, and tackling and studying how organizations can make the mistake of contaminating the professional identity of nurses, of doctors, of caregivers, or even professionals out in this whole fake news phenomenon, and harm someone's professional identity for short-term gains that might not be appropriate.
One of the problems with anything in this realm is that there have been very few penalties for institutions that were not careful about making sure that they weren't contributing to the destruction of somebody's reputation, whether it was a nurse or a doctor. Part of this is also what we call the blame culture, and the tendency to say, well, you're guilty until proven innocent, especially if someone on the outside makes an accusation that something that you wrote was, let's say, plagiarized or was not accurate, or whatever other kind of aspersions might be cast on the work of a very serious professional. You can destroy somebody, and if the hospital or the medical group or whoever it is who they're a part of does not immediately come to their defense, at least on the basis of getting to the heart of what the problem is, then they very often get cast by the wayside. And even if they are rehabilitated later on, in terms of the facts come out that show that the accusations were entirely false, the reputational damage can be immense. In order to show this in a way that's going to get action, and action also in terms of later on governmental, when we put some penalties in place, even for people on the internet who think that they are without any responsibility or accountability. This is where my concept of the red cover report comes in. And just to quickly state what that is, for those of you who haven't heard me go on about this, in the National Transportation Safety Board world, which is the organization, the independent government organization that is tasked with investigating all moving accidents, pipeline, shipping, aviation, highway, trains, that sort of thing. A brilliant organization, only about 390 people, but they have an awful lot of PhDs on board. They have created over time a great ethos for being able to say we don't give a whit about blame. We don't care about blame. Blame is not productive in making it not happen again. What we do care about is finding out everything that happened, everything that contributed when something goes wrong, because there's never just one factor. It's one of the reasons we've got to scrap the RCA, the root cause analysis. There never is a root cause. It's root causes. And unfortunately, we still hang on to that. The red cover report idea is to do what we do in the blue cover, which is kind of an esoteric term for the report that's always issued at the end of an investigation into, say, an area accident. to do that in red cover basically just says we're going to use the same techniques in medicine. Now, not for everything that goes wrong. That would not be possible, because we're talking about at least an order or two of magnitude difference in terms of the number of investigations that would have to be there. It's just not possible. But what is possible is to take things that have been a continuous problem in healthcare and medicine, including the attacks on and the robbing of critical reputational sources, and, by the way, people who have been able to gain a reputation undeserved, either by stealing identity or by prevaricating. To put this in context of how big a problem it is, we need to talk about many different cases, and the way to do that is to talk about them generically in a context in which you can see that things happen over and over again. Now, certainly in cases, for instance, of let's say retained objects in surgery, this is an ideal opportunity for a so-called red cover report. And the idea of a red or a blue or any other color report along the TSB line is simply to say, first, we don't ask who did it, we ask what happened. Second, we analyze the sequence of events of what happened. Third, we lay out on the table without any hierarchical ranking everything that contributed to what happened, and then we make recommendations to make sure that not a single solitary one of those causal links can ever happen again. That's the proper way to do it. As a matter of fact, in just culture, that should be a prerequisite before anybody even talks about whether someone failed to come up to the professional standards we expect of them. A red cover report has more to say in terms of potential nationally and internationally than just what a good standard practice should be, or what not to do, and how to avoid a problem with a particular surgical procedure, or anything else in the way of getting to best practices. It also has a great opportunity to give a spotlight on the things that are a rancid problem in medicine today. And looping back to what I started with and what your question was, one of the greatest difficulties we have right now is knowing who and what to trust. We're in an age in which people are talking about alternate facts, for crying out loud. Well, there are no alternate facts. Facts are facts. We need to get those on the table, especially with respect to how dangerous it can be to have journals, for instance, that have no credibility, but we haven't figured that out yet because people didn't realize it was a problem. Or, for instance, out of my own other profession of airline piloting, we had a gentleman who claimed to have an MD and a PhD who was running around as a cardiologist, writing papers and actually consulting. These are not necessarily isolated incidents, and putting it together in terms of what the overall landscape of this problem is where something like a red cover report would come in not only very handy, but I think it would be of inestimable value.
John, we just want to thank you so much, and on behalf of the nurses and caregivers and professionals that you're helping now behind the scenes with the idea of the Red Cover Report, we just want to extend our great thanks and the gratitude for all the quiet things, John, you do in our healthcare environment. You're truly one of our heroes, and we're just honored to have you actually be one of our lead speakers for our 100th webinar in a row. Thank you, John.
Well, that's graciously overstating the case, Chuck, but I am very, very proud to be a part of this, and congratulations on this 100th.
So we are so grateful to have John with us. He couldn't be with us. He's given a keynote today, but he wanted to be part of the 100th webinar, and he's really charting the course for us in 2017. The lack of, we may lose a lot of the regulatory and safety mechanisms, and it's really going to be on the backs of our safety and quality leaders. One such leader that has just done a terrific job is Jeanne Huddleston, and Jeanne is the first hospitalist at the Mayo Clinic, and she is going to go through a set of slides today. She's spoken 3 to 4 times, and she has told me that she put more slides in than she will cover. So, Jeanne, advance through so you can give us the highlights and give us a perspective on 2017. But Jeanne is I think, one of our greatest global leaders and the next generation of patient safety leaders that are really going to help orders of magnitude improvement across our nation, and I feel the world. She's a hospitalist. She's the chairperson of the Mayo Clinic's Mortality Review Committee. Most importantly, she has been working on mortality reviews for 13 years, and has brought them to prime time nationally. And it's just such a great honor, Jeanne, to have you come back. And you can see by the polling that our audience just doesn't get enough and wants more. We don't want to overdo any one topic, but it's clear that you have just created a hunger for improvement that is just really neat to see. Jeanne?
Thank you so much for all of you who are there, and for Chuck, congratulations on putting together 100 consecutive months of amazing education for our leaders and our advocates and cheerleaders for patient safety around the world. I am just going to briefly hit on some of the high points of things that we've learned, mostly regarding the harm from omission, which I think is an amazing opportunity for our leaders and for all of you who are involved in patient safety. The reason that I think that this is so important is when I went back to school to get my industrial engineering degree, one of the things that was brought to my attention was that in the 70s and 80s in the automotive industry, we had all the pieces and parts in American manufacturing to make the best automobiles in the world. However, they weren't very reliable, they were pretty expensive, and the gas mileage was bad, etc. Entered the Japanese automotive industry, who all of a sudden started making cars better, more reliable, put them together in ways that were more appealing to consumers, etc. We have, like then, all the pieces and parts in healthcare, but we're not getting the great science, the amazing people, and all of the technologies and drugs, everything put together in the right place at the right time with the right provider for the right patient, reliably. According to the Dartmouth Atlas, we're only getting this right approximately 50% of the time. We must do better. And we're not going to get better if what we do when we're studying our mortality reviews or our readmission reviews is only identify the hacks and the HAIs. We have to identify those things when the pieces and parts weren't put together appropriately or reliably. And just like Dr. Nance just said, it is not about the person who did it, but what went wrong and what can we do better. And that's the only way we're ever going to get healthcare to be reliable and have it look the way we want it to look for every patient every single time. So why would we do things differently? Because I think that the American healthcare system needs to be better. I think we all believe that we can do better and that we have to be able to give patients the best medicine has to offer every day, any day. So we developed at Mayo the safety learning system. We called it Mortality Review when we started, and as I've mentioned before, that was just a convenient cohort of people to study. It was an easy group of 100 patients to identify. It was an easy group to study, and we believed at the time in 2003 when we began that they were going to have the richest source of learning for us based on everything that had come out of the IOM reports. So the part one of our safety learning system was to influence and inspire our leaders to make a difference, not just give them run charts of patient safety events or hacks or HAIs or even their mortality numbers, but we wanted to inspire them to do something about what we were learning. That's become the afferent limb, the identification of the process and system failures within our care delivery. The charge that we wrote in 2004 remains the same. And you've seen this slide before, but I want to point out again is that what we were attempting to do was identify a meaningful mechanism to learn, to advance organizational learning so that we could thoroughly understand what was going wrong within our organization, measure it, and improve it. If we couldn't understand, measure, and improve, then we would have scrapped our multidisciplinary, multi-specialty review process and found something else. But through the numbers of cases that we've done, which is now more than 12,500 consecutive reviews, and the things that we've been able to understand, measure, and improve, we have made meaningful system-level changes that have saved lives in our hospitals and other hospitals across the country. It's not peer review. It's not about who did it or who was there. It's about the system, because if there's a misdiagnosis of sepsis or an omission of following vital signs or anything along those lines that's happening on every floor in your hospital, then that's not an individual provider problem, because it's all of the providers that are in the system trying to deliver care for your patients. It's about the system supporting the patients and the providers to do the right thing every day for the patients in their journey under your care. We defer to expertise, which is a high reliability concept. If there is a breakage in the system and the process in delivering care on the floor, who knows better about how to fix that than the people who were actually standing on the floor at that time? Everything needs to be recorded so that we can learn centrally. That means transparency of data. And we need to have all of our nurses and doctors, regardless of specialty and location in the hospital, learning together to have the best results. That all being said, every hospital is different, so things have to be implemented locally for things to work. This is a schematic. I'm not going to touch on the details other than to say that our process is a combination of individual reviewer work and committee consensus building to create the learning that we carry forward to both our clinical practice and our quality groups. I want to spend just a second defining the difference between our process and traditional peer review, because this is the most difficult part for the physicians to get around. In a traditional peer review, you have a problem that's identified, it's reviewed and discussed by the peers of that individual, and that individual is notified of the findings of the discussion. In our safety learning system, we are selecting cohorts of patients that we have yet not been able to figure out how to help them the most, whether it's a readmission cohort or a particular PSI cohort or a total knee cohort where the institution can't get their arms around the bundle and they're going to be penalized. Regardless of what the cohort is, we take that cohort, we study the members of that cohort, starting with just 100 of them. We review and discuss the findings we have in our multidisciplinary, multi-specialty practicing provider groups. We identify opportunities, and then we share that learning broadly. So it is philosophically a very different approach. Because what we're looking for are those system failures. System failures like the triage failures that we identified that created a 62-fold increased risk of death in our hospital, or delayed or misdiagnosis of mesenteric ischemia, or the interactions between levaquin and unknown previously prolonged QT intervals, or our patients who died following their elective orthopedic surgeries because they had unrecognized obstructive sleep apnea and they were on PTAs. All of those are omissions, and all of those are system-level issues. This is an example of that peer review versus safety learning system from one of our collaborators in the patient safety learning system collaborative that we have going. They had a 56-year-old who came into the emergency department during the night, and a very busy night, and she was complaining of weakness and came in via the ambulance, was found to have a potassium greater than 8 after the ECG to the left there was obtained. She was treated with a single dose of insulin, calcium, bicarb, glucose K-exolate, standard treatment. There were no repeat labs following that initial treatment, and 4 hours later she coded and died in the CT scanner. In peer review world, there would be a letter sent to this individual about their monitoring of the hyperkalemia following their initial intervention. Why weren't more labs drawn? Why did the patient go to the CT scanner when clinically, obviously they were in an acute clinical crisis? Well, what if you knew from a system perspective that behind that individual's work, all the beds in the emergency department was full. This patient was actually boarded in the hallway. There were more than 20 patients waiting in the emergency room, waiting room. It was the middle of the night. Interventional radiology was not available to put in the emergent dialysis catheter, and suddenly the CT scanner became available, which I guess it was a really rare sort of event. The patient was coding in the room next to this patient who was out in the hallway, and all the ICU beds were full. Well, with all of that background information, it's clearly not just an individual who forgot to order a set of labs. There were a lot of systems and processes that were breaking down that evening, and those providers in that emergency room were heroic in making everything else happen around them. The omissions and the commissions at Mayo Clinic that we've identified fit with the reports that Dr. Denham shared with us at the very beginning, the ECRI Institute report that said that number 2 problem was failure to recognize deteriorating patients. Well, gosh, our top 2 related initiatives are failure to recognize or delayed recognition of a diagnosis. And if you delay the recognition of a diagnosis long enough, you end up with failure to rescue, which is our number 2 related omission, the failure of our providers to recognize and rescue acutely deteriorating patients. It is a really big deal, and fixing those 2 things and going after those 2 things will have a huge effect in how we do. But people often say, "Oh, you're Mayo Clinic."
Jeanne, if you could,
yeah.
Jeanne, if you could do 5 more minutes, I
Sure.
know you have a bunch of slides, and you can advance the slide by putting the slide number up in the window, and you can move right to the slide if you like. Or
Perfect.
I can do it for you.
Yeah, got it. People say you're Mayo Clinic, you're different, we can't do it the way you're doing it. Well, this is a hospital out of Canada, and they did the interdisciplinary approach that we had shared with them. They dropped their O to E, not just by improving their documentation, but also by dropping their raw mortality rate. They improved their sepsis survival, and more importantly to me, they identified that delirium management was an issue while doing mortality reviews. And by going after that, they had a 2-fold increase in percentage of patients who were discharged to independent living. Now, that's impressive work. Also not Mayo, this is our Safety Learning System Collaborative, omission and commission, again, coming out in spades, the top 80% of things that we can do in all of these 21 hospitals in the United States who participated in contributing this data include omissions. None of them are commissions. So again, it's something we really need to focus on and work on in this very systematic way. I'm going to go through these slides that show you who's participating. Our number 1 in the collaborative was palliative care opportunities or end-of-life opportunities. And by going through a systematic approach to identify the process and system failures, not only do quality leaders get what the information about what the biggest opportunity for improvement is, but they also get the marching orders for the next few steps of how to go after it. So in this case, our hospitals found that the palliative care team should have been called or could have been called sooner. Great, so now you've got a palliative care team who knows they need to be involved more. What do they work on? Where in the world do they begin? Our hospitals have told us the top 2 things they need to work on after establishing the palliative care team is goals of care conversations, teaching your providers how to have goals of care conversations like Aurora Health System is, or like Sharp is doing, and then trying to address or beginning to consider conversations around excessive and futile care. Now your hospitals, your groups, your workers, your safety evangelists have something to start with. This allows meaningful and actionable information, not just what needs to be fixed, but prioritizes and helps teams figure out where to start. Where we're headed, we're going to go into some action modes, and we're going to start learning from the living. And I'll stop on this next slide, which is the Safety Learning System efferent limb, where systems architecture and engineering methodologies are used to mitigate harm or increased expense caused by prolonged length of stays or readmissions, etc. So we're working on cohorts of readmission, total knees, and other aspects of things that have been difficult for us to solve. And we need the combined learning and execution of an efferent limb, an effector arm, so to speak, to actually make a difference and move the numbers.
Thank you so much, Jeanne. And I want to draw the attention of our both live audience and our on-demand audience to go back to safetyleaders.org for the deep dive content. And we'll also have links to a very deep dive, 1.5 hours on the reviews and 1.5 hours on how to apply them that we shot in Texas in the last 2 weeks, and those will be up as links on the Global Patient Safety Forum, and we'll have them come from Safety Leaders as well. So, and we want to thank you, Jeanne, so much for your pioneering work and for introducing us to Liana Orsolini, who's our next speaker. You saw from our polls that the audience really wants to hear from those that have adopted this. It's always easy to say, well, we're not the Mayo Clinic, but other organizations have done a terrific job, and Liana is the Care Delivery and Advanced Practice System Consultant for the Clinical Excellence and Innovation area for Bon Secours Health System. She leads all advanced practice clinician initiatives across several states in order to liberate their potential for their fullest extent of education. She is the system lead for Mortality and has an extensive bio that you can see on our website. Prior to going to Bon Secours, she was the Robert Wood Johnson Foundation Health Policy Fellow at HHS, and I'm sure those experiences were just terrific. Liana also will share a personal story in her presentation, and we're just delighted to have you, Liana, speak with us today.
Great. Thank you so much, and it's really great to be here. It's such an honor to be part of a group that really cares and has so much passion about preventing preventable deaths. So I'd like to just start by introducing who we are as our Bon Secours health system. And we are an integrated health system mostly on the East Coast, from New York to Florida. We have, out of the 19 acute care hospitals that we have interest in, we directly control and own 12. And we also have home health care, ambulatory care practices, physician practices, and some advanced practice clinician-led practices as well. We have retirement homes, nursing homes, so we have the full gamut. We also have a multi-state MSSP ACO, and we have been very focused on population health. So also, I just want to say that our mission, it's so easy to work in this health system because our mission is about being good help to those in need, especially the poor and the dying. And the Sisters of Bon Secours have focused our care areas in underserved communities. So, for instance, our Baltimore hospital and clinics are just 2 miles away from where the riots occurred. And we do serve people in the foothills of Kentucky where there's a lot of poor miners and other populations that are extremely underserved and impoverished. So with that spirit of being good help, we have developed this 3-year strategic quality plan that I utilize to leverage our work with mortality. So to be person-centric means to prevent preventable deaths, and on our safety and reliability journey, that is key front and center. It also strengthens our ability to remain a top health system, especially for those in the communities. So we also culturally abide by the IHI's mission of telling the patient's story. We feel that's very important. And before we were really going down the safety and reliability journey like we are today, we adhere to starting our huddles, our meetings with the patient's story. And, you know, it brings us back to the why of what we do, and not just our work, but our ministry to prevent preventable deaths and patient harm. And we like to put ourselves in the place of patients and their families. So we often ask ourselves, is this something we would have been okay with had it been our mother or had it been ourselves? Are we okay with that? And so based on that spirit of really wanting to be in the patient and the family's shoes and to provide a care environment and optimal care, if that would be good enough for ourselves and for our family, I just want to share a story about my mom who recently died on January 1st. And because of 2 errors of omission, and I just have to say she wasn't cared for in our facility, and I'm her executor and on her advance directive, so this is not violating any HPI, and it's part of the legacy she leaves behind. So while I believe that my mom passed away according to God's plan and her suffering of living with multiple sclerosis for 50 years has mercifully ended, she died due to 2 medical errors of omission. And they are medical errors of omission we know are critical procedures or treatments which are excluded and may lead to a bad outcome like death, which is what happened to her. So a few years back, when a physician tried to perform a colonoscopy on Mom, he failed to get the scope past the juncture in her colon. And so Mom assumed that since she had a failed colonoscopy, she could never have another one. The physician failed to reschedule another one at a later date, systems problem, as well as failed to inform her that a failed colonoscopy does not mean they would be unsuccessful in a subsequent attempt. So when she started having symptoms of colon cancer, she went back to see a different gastroenterologist who assumed she did not want to have a colonoscopy because she stated that she couldn't have one. And I met this gastroenterologist. He's the nicest, sweetest, patient-centered practitioner, one of the few I've met that are in his level. I mean, he is someone you would want to be your friend. He's amazing person. Anyway, her barium enema, CT scan, and swallowed pill camera tests all came back negative. While the pill cam is a great way to look for cancer in the small intestine, it frequently fails to find it in the large intestine. So the second act of omission is no one ever told my mom about the pill cam's high failure rate for detecting colon cancer. So unfortunately, when she started bleeding and had to be taken to the hospital via ambulance, she successfully had a colonoscopy which found the cancer. Unfortunately, it had already spread to her lymph nodes and she couldn't tolerate the chemo. When she found out about that she could have had a repeat colonoscopy, it devastated her. And she courageously let the gastroenterologist know he should have educated her about this. So this is a very personal issue for all of us. I can't imagine that anyone on this call has not experienced a friend or family member or a neighbor or someone they knew that felt the effects of an act of omission or commission. So what inspired us to take this journey for centralized mortality reviews? And I just had to put Jeanne Huddleston's picture back up here and her article, and you can see that I highlighted it in several places. We met Jeanne Huddleston, invited her to speak to our health system, and just got so incredibly inspired. And so we started centralized interprofessional mortality reviews about a year and a half ago, and we also contracted with HPI, which is now Press Ganey owned, about classifying serious safety events. So where does all of this work sit in our organization? The following slide shows that our organizational structure, if we can advance the slides, please. You can see that in the green is our Safety and Reliability Council, which is at the corporate level, and the mortality work, which is the red box, sits underneath the overall safety and reliability work. So that's the way we kind of align our HPI work and our safety and reliability journey, and we hold mortality in that structure. And the structure allows us to communicate it down to the local system level and to grab our champions to socialize the change. So we basically have 3 teams, and the teams have grown. Each team looks at and reviews a mortality case, and we do cohorts as well. And they do an interprofessional review, and we have since switched to Jeanne Huddleston's tip sheet, which is fantastic, on how to look at different parts of the chart, especially nurses' notes, to gain insight into possible acts of omission. So we utilize our advanced practice clinicians, our RN quality people, and we also brought in our coding and CDMP or documentation professionals, and I'll tell you why. So if you look at what we learned that early on that we have too many fallouts in fluid resuscitation with sepsis. So we added fluid resuscitation to our sepsis order sets. We had gaps across our market with use of BiPAP across all diagnostic groups, and we found that as we were going through our sepsis cases. So it took us a year, but we formed another interprofessional group to come up with a standardized evidence-based policy on use of non-invasive ventilation. We found antibiotic stewardship was a problem. I mean, all those sections the collaborative found and the Mayo Clinic found, we saw them in these mortality reviews. We have so much variability around knowing what to do with a high troponin level, or that we were shocked that we had a 20% opportunity, not just in documentation, which is physician and provider led oftentimes, but actually we had found that in one of our states we had hired so many new coders who were making mistakes. So, and I don't know if it's traditional for coding and documentation specialists to kind of, not play well together. So we got them to start working more interprofessionally and more collaboratively, and we're trying to leverage more physician and provider education around documenting in an ICD-10 value-based world for greater specificity and greater accuracy of the patient's condition. We also found that most patients hospitalized with end-stage heart failure do not have an advance directive. We uncovered what's considered a sentinel event in the UK, that we have a lot of oxygen disruption around patient transport to and from ancillary departments. We have more failure to recognize, escalate, and rescue than we care to admit, even though we use a Muse system, and we're really focusing our efforts right now on this. And it's not just because we have, a lot of new graduate nurses. We think it's multifactorial, and we're trying to dive into better real-time utilization of our modified early warning system. And physicians and providers are not having advanced care planning conversations with their patients. So you look at the next slide and where we have to go. If we really want to move the mortality needle or the outcome needle, which we've heard on other webinars here, that sometimes the outcome is a good death because not all deaths are preventable, we really need to go upstream. So we set a goal in our health system that at least 10% of our patients in our ambulatory care settings would have an advanced care planning note completed. And 10% is a very low goal. But if you look at, this was last month, we've crept up a little closer to the 10% goal in some of our markets. You can see that in some of our markets, we had just barely reached over 1% as of January. So it's a very uncomfortable practice, and I'm really hoping with the new administration we don't do away with Medicare's reimbursement of physicians and providers paying, getting reimbursed to have these critical, crucial conversations. So what about the gap? What is this gap that we discovered, or where do we go from here? So on the next slide, you can see this picture of a beautiful ocean with two huge cliffs. One more slide, please. And there's this huge gap between the two cliffs. Next slide, Zach.
I'll back it up. We'd already gone through the gap, but we'll back it up to the cliff.
No. Gap is after AC. Oh, there we go. Yes, the gap.
Yeah.
So the gap was, once we uncovered all these problems with our centralized mortality reviews that transected our states and our hospitals, it was like pulling wisdom teeth trying to find people to lead the initiatives. And, your bandwidth as a leader is only so wide. So we found that most of the time, our mortality coordinators, our quality professional, master's degree nurses were either spending time doing data entry into our mortality registry and therefore, or spending a lot of time discovering what the problems are and not enough time or FTEs in closing the gaps and in doing cross-system initiatives. And we're still struggling with that. So if you go to the next slide, we will develop based on our priorities ad hoc action teams. So for instance, we did this for our non-invasive ventilation. We got stakeholders, different interprofessional stakeholders like pulmonology intensivists, a certified registered nurse anesthetist, a pharmacist, critical care clinical nurse specialist, educator, a director of respiratory therapy, and we put them together with an executive sponsor, myself, and a program manager from Premier, Elena Malfitano, who's just fabulous. And we took all the problem areas we found with using BiPAP in our mortality reviews, and we built a chart of all the problem areas, and then we took all the 11 to 12 hospitals, their policies on non-invasive ventilation and BiPAP use, and we crosswalked it against all the areas of concern we found and the deviations from the standard of practice in our mortality reviews after looking at 10% of the mortality cases over a certain period of time that had utilized BiPAP. And we found that even our best policies in our system did not address every level and area of concern. And we found that even our not-so-good policies did address some gems, like some aspects of interprofessional practice. So we we looked at the literature, we reviewed the literature, we put together all the points of great practice, and we made it an interprofessional policy that actually included the patient and their family. So there's a part for physicians and providers, there's a part for respiratory therapy and nurses, there's a part for families and patients. And it was a really wonderful development of promoting interprofessional practice. And to John Nance, I was so excited when you talked about the checklist because we added a BiPAP or an NIV 15-second timeout, and it's based on Atul Gawande's work on the checklist. So that was an innovation. So last slide, what are our results? It's the very last slide of the deck. If you could scroll to that, Dr. Denham, I'd appreciate it. Great, thank you. So we didn't start this work really until, about August of 2015 is when we decided to be much more focused on centralized reviews. Or actually, we started a few months before that, but I took over in August after the committee had been going on for about 6 months. And it takes a while to change and to change practice. But what we found, and you can see mortality expected are the red lines over mortality observed, and the bigger the space or distance between the red line and the top of the mortality observed blue column means you're doing really great. We have finally started to see major results probably since about February of 2016, with the exceptions of April of 16 and September of 16. We are now at, if you look at our adjusted observed over expected, we are at 0.56, which is 0.01 away from target, and we have never reached a mortality rate that was that good. So we have really started to see the effects of the culture change, the paradigm change, the initiatives, the focus on preventing all preventable deaths. So it's been a great journey. We still have a long way to go. I didn't add a next step slide, but we're very, very excited about this work. Thank you.
Well, thank you so much, Liana, and I know that we'll have you and Jeanne and others come back to speak because we're just getting this overwhelming response from our audience, and we're going to pull the audience shortly, so stay with us, audience, and Dr. Boats is going to give us an update on medical tactical program and Chief Adcox on workplace violence, but we're going to put up a poll, and we want to make sure to capture the interest that folks have in the topics, and the two really hot topics of the mortality reviews, the triage and failure rescue issues we want to, and misdiagnosis. So we want to make sure to address those. Well, now it's a really great pleasure to introduce our final two speakers, and Greg Boats. Dr. Greg Boats is professor at the Department of Critical Care, Division of Anesthesiology and Critical Care at the MD Anderson Cancer Center, where I have the pleasure of training and doing my medical oncology as a radiation oncologist, and is really the visionary inspiration that really got us on the track for the MedTac program that has everything from an after-school program and scout program right through to a comprehensive program for practicing clinicians seeking risk education credits and recertification on critical issues. And Dr. Boats is very talented. He has dual appointments also at Stanford Medical School. And on his time off, I'm always proud to say that he's teaching nurses and trauma nurses in life flight helicopters, which is always a crowd pleaser to the little boys who we introduce him to when he is helping teach MedTac to kids in the pilot programs we have. Go ahead, Greg, and please give us a quick update on MedTac and what it is.
Well, thanks very much, Dr. Denham, and it's a pleasure to be a participant in the 100th consecutive webinar. I know many of you have seen some of this material in previous webinars. Like many of you, I entered this journey in quality improvement and patient safety about 15 years ago and worked very hard to try to make changes in our care delivery to make it more safe and effective for our patients. But more recently, my focus has changed a little bit. Our institution has put some attention on institutional health to look at a broader focus on patient safety to include our caregivers, so those we serve and those who serve, and even a little bit more broad in focusing on caregivers' families and the effect that that can have on caregiver performance and the communities in which they live. So MedTAC is a program that's a strategy to look at the health hazards in those populations. You've seen this before. We looked at the high-impact care hazards in otherwise healthy people. These 8 categories are areas with potential preventable mortality in otherwise healthy people. And we put a program together to teach these skills, not only the education, but also training in actions that can help prevent death or serious morbidity with these problems. So our approach has been to look at these high-impact care hazards and impart lifeline behaviors in our students to give them the skills to intervene to try to avoid morbidity and mortality. And it's really been a pleasure to see with our implementation of this program in a school in California how truly effective these interventions can be taught, and how well these kids embrace the life-saving possibilities of these skills and work so hard to master them. If we look a little more closely at the cardiac arrest problem, we've been fortunate to have a paper from the Institute of Medicine come out recently looking at strategies to improve cardiac arrest survival. And this really speaks to something that we've talked about as part of the MedTAC program. You know, the response from EMS or first responders is not immediate. And there's an amount of time in which activity aimed at reversing the problem has a great impact on the survivability of the patient. That seems to be the impetus behind focusing so heavily on good quality CPR and the availability of AEDs in the community, so public access to defibrillation to try to improve outcomes in that gap of time before first responders arrive. This is the bystander care or immediate responder model that is so important in the chain of survival. If we look in that report, it shows us this figure, which is the phases of translational research, sort of from bench to bedside, and then from bedside to real-world implementation of these skills and knowledge to try to help save lives. We've seen in cardiac arrest, the implementation of quality CPR and early defibrillation have made a tremendous impact on survivability, and not only survivability, but survivability with good neurologic outcome. In opiate overdose, I know all of you, like I do, see almost on a daily basis reports in the news about the tremendous epidemic of opiate overdoses we're seeing in our communities. And the reality is that opiate overdosing is a completely preventable mortality. If you can recognize it and intervene, people don't need to die. The mortality is from the effect on the respiratory system with hypoxia, which leads to brain death and eventual death. If you can recognize and intervene with either rescue breathing or a combination of rescue breathing and the application of Narcan, people don't need to die. I think one of the most important statistics that came out that really drove this point home to me is the CDC report from 2015 showing that the deaths from heroin overdoses in the United States have surpassed the deaths from gunshot wounds in our country. That's a staggering statistic. Other areas of focus in the MedTAC program has been on major trauma. We were lucky to see the report from the National Academy of Medicine looking at a national trauma care system where we're taking a very good system of trauma care and looking for opportunities to reduce the preventable deaths that still are part of our performance gaps in trauma care. And this effort, led by Don Berwick, who we all know from IHI, really encourages us to take the lessons learned from military trauma care and embed them in civilian care, because many of the deaths that we're seeing in our cities now are preventable with the use of things like tourniquets and compression dressings and other things that were learned in the battle campaigns over the last 10 years or so. That's led to now a public access to bleeding control devices similar to the public access to defibrillation devices that we saw in the last 15 years from the American Heart Association and others. This public access to bleeding control involves teaching people how to use tourniquets and compression dressings to stop major active bleeding that can lead to death in just a few minutes, certainly before first responders can arrive. And in our first course in this school in California, we've seen third, fourth, and fifth graders use tourniquets effectively to stop the potential bleeding from a serious injury, whether it's from violence or from an industrial accident or something that happens, around the house. The example is significant injuries from objects flying out from a lawnmower when one's working in the yard. These are efforts that are being taught to try to reduce the preventable death from major bleeding. All of these efforts with MedTac is really an effort at implementing translational safety. So to borrow from the translational research spectrum, really what we're trying to do is take that knowledge which we've gained in the bench-to-bedside endeavors with patient safety research and move them into the T4 phase at the end, where we're translating that into real-world actions and knowledge for bystanders to intervene, to understand the circumstances and provide quick action to save lives in these several high-impact health hazards. So what are we doing with translational safety? I think if I had to say it in one sentence, I would say it's trying to translate what we know into what we do. It's taking knowledge to action and training people with very simple skills that can have great impact on the early management of people with these high impact health hazards. It's the use of deliberate practice in real life scenarios using immersive simulation to practice these life-saving skills so that they become part of your armamentarium. And if you are a bystander in a circumstance where someone has a sudden cardiac arrest, if you come upon someone who may have had an opiate overdose or any of the other high-impact health hazards we've described, you have an idea of what to do. We use in situ simulation in some circumstances to assess performance. That's systems probing using simulation. And once you've done that, you can draw inferences into the performance gaps that exist. That is, the difference between what we perceive our behavior and performance to be and what it actually is. And I think all of us know in our healthcare organizations that those performance gaps are real. And certainly the care that's delivered in our communities by our bystanders can have significant performance gaps, and we want to do things to narrow that as well. We use a simulation technique like rapid cycle deliberate practice to foster good behaviors in those very stressful situations and try to extinguish undesirable behaviors that may not be helpful to the victim in those circumstances. And we borrow from the aviation model for competence versus currency. I'm a board-certified anesthesiologist and intensivist, but I haven't done obstetric anesthesia in many, many years. And so even though I am deemed competent to do that by the American Board of Anesthesiology, I'm not current in those practices, and I really shouldn't be the one providing that level of care. But if I were to do a number of OB cases under the guidance of an obstetrical anesthesiologist and regained currency, then I think I would be a more competent and current provider of care in that in that sense. MedTac is designed to be a course that not only delivers competence, but allows for regular practice with maintaining currency. Think about your own circumstances in your institutions when people take basic and advanced life support courses every 2 years. How comfortable are your providers in doing good, high-quality resuscitation in the event of a cardiac arrest when their last opportunity to practice was a year and a half ago? It's not very realistic. We need to move towards models of currency so that we provide the best care that we can to our patients. And obviously with MedTac, we're trying to move towards behaviors that are part of high reliability organizations. We want to foster good situation awareness, teamwork and communication to allow people to have the best opportunity of providing life-saving interventions. Chuck, I'll turn it back to you, and I look forward to hearing the comments from Chief Adcox.
Thank you so much, Greg. And Greg is one of the few people that has a fellowship in simulation from Stanford and has just been a really great guiding light on our team taking on the MedTac issues. It's now our final speaker, and what I'd like to do is while we listen to him, and then I'll address the polling questions when we have our reactors. But Kyle, please put up our polling questions because we'd love to get you as an audience to let us know the topics that you'd like to have us address. And I will read the questions to you right now, but I'll introduce Chief Adcox. But Kyle, go ahead and put the survey up if you would. Chief Adcox and his colleague, he couldn't speak today, be on live, but we have Vicki King, one of his wonderful colleagues and a close colleague of ours, working together in this space on MedTac and the threat continuum. But Chief Adcox has an MBA. He is Chief of Police and the Chief Security Officer of the University of Texas MD Anderson Cancer Center there with Greg. He's has 37 years experience in municipal and campus policing. He's been a chief of police. He's held numerous roles, and you'll see his bio on our site. He's had wonderful awards, and he is just one of the most wonderful men I've had the honor to work with. And it was his prompting that helped Greg and I expand the focus on active shooter events in the hospitals and healthcare organizations to understand more about what's going on in the schools. And without Greg and without Vicki and without Chief Adcox, we would not have a MedTac program and not have a program for schools and for businesses and for healthcare. So it's a real honor to introduce Chief Adcox, and he will be addressing the issue of workplace violence, which we know to be 5 times the incidence of other sectors. So it's a critical issue, and MedTac also focuses on bullying, and this is the on-ramp for this kind of violence. Chief?
Well, thank you very much for that kind introduction, and let me reiterate that the MedTac is really the basis and the foundation for everybody when you look towards preventable deaths and what we can do as a foundation. But today I want to talk more around this workplace violence and a little bit about what we're doing. But if you look at that first slide, that's a recent GAO report. And this recent report, along with other review of workplace violence in healthcare studies, it clearly shows that workplace and healthcare is an enormous problem, and that you will see as we go on that it is a very underreported issue. So the next slide that we have will show you that the Bureau of Labor Statistics shows where healthcare is 4 to 5 times the frequency of workplace violence events than any other sector. And so you can clearly see that this has been a consistent issue over a period of years. And in our next slide, it shows where these are the typologies that have been identified by the Federal Bureau of Investigations. And in 2016, the International Association of Healthcare Safety and Security, they produced a crime survey that they do every year. And in that survey, they found that type 2 typology was the absolutely most frequent that you have. In fact, they found that 83% of all aggravated assaults and 91% of all assaults were of the type 2 version, and that's why we have it here in the box. But again, let me talk that the major problem that we're seeing is that this whole issue of workplace violence in the healthcare sector is tremendously underreported. And basically, this is borne out in virtually all the studies in this area that we've looked at. In fact, a very recent study that just came out from Dr. Lisa Pompey off of a 5-year federal grant, it actually shows the fact that workplace violence is underreported. And she specifically looked at this type 2 events. And then there's also the most recent data we have from the National Crime Victimization Surveys that they published and also cited in the United States Department of Justice Workplace Violence Report. Again, it speaks very heavily to how underreported they are. So the next slide is a little example of how we have chosen to kind of outline this and how we've chosen to approach it. And this is what we call our crisis continuum. So basically, there are things that are going on, and they start going up this escalating threat area. And so at some point, they're going to get to an inflection point. So the important piece here is that there needs to be intervention either right at that inflection point or before. Otherwise, it'll lead up and likely to have a catastrophic event. But if you look there, you can easily see where there's an information gap. We simply don't know what's going on. So it's impossible to assess or even to take action on anything that you don't know what's going on. So this is why it's very important that we have systems in place where we're getting this information and that it's got the right people looking at it, multidisciplinary, cross-functional team looking at it and taking those intervention actions ahead of time before you get to this crisis. The next slide is the future of healthcare threat safety model, and we believe that this is a holistic approach, and that in order to accomplish this, it says it all there. In order to have early identification and very quick intervention strategies in order to save lives and prevent violence, you simply have to look at the organization as a whole. And so you have to look at your hospital or your healthcare organization from an organizational health and an individual wellness approach. And again, this particular type of threat management is a prevention model and not a criminal justice or a prosecution model. And if you don't have it in this fashion, we don't believe that you'll be able to really get the buy-in and everybody really wanting to come to the table and help everybody, because all of these different individuals have the ability to help. And so what we see in healthcare is there's a tremendous amount of specialty, there's a tremendous amount of silos, and everybody has a job to do. But when you have this type of organization, what you're going to simply have is you're going to have gaps. And you may not have the reporting, you may not have the information and the people acting on that soon enough. So when you think about all the great work that Dr. Jeanne Huddleston has done from Mayo around this systematic approach, it's how do you ensure that you get the information and you have the right people looking at it, looking at the right data, and then getting early interventions through a systems approach. And she's done wonders with it. And actually, what we're doing here pretty much dovetails to what she has talked about in the mortality studies that she continues to do with Mayo and her consortiums. And so it is very important that you get this information early enough. I mean, the fact that at Mayo they were able to identify sepsis 30 hours earlier than in the past simply because they implemented the systems approach, they were able to save lives. And the fact that they were able to find that the vast majority, close to 80% of deaths that were actually the result of omission versus commission is just huge, because that's not where our standards are at. That's not where people are looking at. So again, we have to go back in here and look at how do we do this all together to make the healthcare sector safe. So if you look at the next slide, even the most recent article we have from the Journal of American Medical Association, Dr. White specifically highlights, and you can see it there, it's the same basic model. Every alleged report of workplace violence needs to be assessed. It needs to be looked at. It needs to be evidence-based, data-driven, and assessed by this multidisciplinary cross-specialty team so that the right folks can get engaged and and develop these intervention strategies early. But if we can find out what are the key types of data and information coming in, the behaviors of concern, the medical issues that are causing concerns, say, with patients, and get it to the right people, we can prevent workplace violence. We can prevent individuals from getting injured or injuring themselves. And I think that's very critical. So to wrap it up, Charles, I think that's really where we think the future workplace violence is going, and be glad to, to take any questions or anything down the road.
Thank you so much, Bill. That is just terrific work. And maybe answer one question or give us a little bit of a teaser as to what you're doing at MD Anderson and UT Health in terms of de-escalating or getting left of boom of the bad event, how you can actively de-escalate things that could be prevented.
Well, we have a very, very robust education and training program of all employees, and so we get folks to report behaviors of concern, and then we have a threat management approach where through a behavioral intervention team of a multidisciplinary cross-functional team that takes this information and starts to evaluate it. And remember, each person on the team has different pockets of information they bring to the table out of their silos. And then the police department, the security police department, we're the ones that investigate. We're the rapid response threat assessment portion of it. So we get engaged very quickly, and we do it all together. We share information. There's transparency. There's full disclosure, and everybody's looking at it from how can we help somebody. And so these are the types of things that we're doing. We're also working with, how to develop the next level of science. And it's funny because if anyone's ever read the book, The Way of the Peaceful Warrior by Dan Millman, he says that the secret of change is to focus all your energy not on fighting the old, but on building the new. And that's really what we're trying to do, is how can we look at the most progressive ways of early intervention so there can be true prevention. And that's what we're doing here at MD Anderson and UT Health.
Well, thanks, Bill, so very much. We'll have you back in 2017. We really appreciate it. We know that you're off-site and recorded this for us, and we're so grateful. Thanks, Bill. So we'd like to now turn to our reactor panel, and I'll put the polling questions up again. We'll go a few minutes over, but what I want to do is first have Dan Ford react, and then Becky Martins. We'll go through our patient voice of the patient leaders, and then ask each one of you speakers that are live to make your comments or thoughts on the other speakers' presentations. Dan Ford first.
Yes, Chuck, you asked me to talk about my thinking about root cause analysis and inviting patients and families, and I will cut this down into just a very few comments. We all know what a root cause analysis is. We know that it's needed way too often. We had a medical error tragedy in our family some years ago, and for about 14 years, I have been doggedly persistent in encouraging providers to invite the patient and family to participate in the root cause analysis. I use the word invite. It's not for everybody. Not everybody's going to accept. I strongly believe, and it's very much of a hot potato with providers and their attorneys. Very few are yet doing this. I strongly believe it will reduce medical errors. It will help to reduce. We can learn much from patient-family involvement. It will facilitate the healing by all involved. It will help the business case, and it's the right thing to do. Most hospitals, if not all, are promoting patient-centered care, the partnership with patients, transparency, really caring about patients and families following medical errors that happen well into their care, and they're genuine and real about that. But I really think we're being disingenuous if we do not also invite them to participate in their own root cause analysis. And we need for that provider, patient, family engagement to continue even when these things happen. One very quick final comment. I think we always need to live our values and according to what I would call our own true north, whatever the source of that is. And there's a quote from C.S. Lewis that I think would seem to apply here. And I quote, "Education without values, as useful as it is, seems rather to make man a more clever devil." End of quote. There's just too much, and this is not intentional devilish behavior, but the leaving of the patients out is typically deliberate. And I just don't think that's right. And so once again, I put a pitch in to all listening that we do that. Thanks, Chuck.
Thanks, Dan, and we know that you've got a publication in 2017 that'll come out on that. Becky Martins, kind of react to what you're hearing about the Mortality Review. You've had a bad event in your family that brought you to become a patient, just a wonderful patient safety champion. From what you heard today, comments that you'd like to make?
Thanks, Chuck, for inviting me to be part of the dialogue this afternoon. I'm really struck on the segment on workplace violence, and I think it's a heavy, a tough subject matter to discuss. And when I listen to the stories, it's a reminder, and it's a mirror image of just how broken some people's lives and worlds can be. I think the research also demonstrates how broken health systems can lead to these devastating, preventable areas of harm for patients and families, both including, on occasion, commission and omissions. I really just want to thank the presenters for sharing their knowledge and their experience with all of us today, for closing the gaps and making both our health systems and our communities safer. I'll turn the call back over to you, Chuck.
Thank you so much. And Arlene, we'll come to you at the end because you're our voice of the patient and close, and I'll ask you a question and then have you close us. Jeanne Huddleston, what would you like to say? And I'll put the pitch out to our audience to join your collaborative, but what would you like to share with us as a final comment?
Well, I just want to thank everyone for their ongoing interest and willingness to continue doing this work and learn as a community involved with the TMIT organization and under Dr. Denham's leadership. We're learning a tremendous amount as a collaborative, and it's been really helpful to all involved to learn how to do these reviews together and what to do once we find something, and watching sites actually implement things, similar to what Secours is doing, and Sharp and Aurora and others who are making meaningful gains in their clinical practices because they're willing to learn and ask themselves the questions, what can we do better? And I think that's a crucial place to begin.
Great, thank you. Liana, you did such a wonderful job threading the needle of what our audience said. They said they wanted to hear about others out there that have taken the journey, and you just couldn't have done a better job in the time allotted. It was fantastic, and we want to have you back. But other comments that you'd like to make, Liana, before we go to Greg?
No, just I guess my comment is thank you for all of you who are involved in this work and put your whole heart and minds into it, because, you know, we owe it to those who come to us and trust us with the lives of those that they love or with their own lives. And we must always strive to do better because we owe them that much. I mean, if we're really here for a purpose, it's to alleviate pain and suffering, not to create it. So thank you very much for all of your work in this area.
And we want to thank you for sharing your mom's story because it's so close and personal. It's easy to distance ourselves, and you've shared a gift with us, and that is terrific that you did. And the stories are just very powerful. Greg, your additional comments from what you heard today and what you want us to champion in 2017.
Well, I remain very enthusiastic about the work that Dr. Huddleston is doing in mortality reviews, and I think we all should look at implementing that sort of methodology in our own institutions to look at the unseen and unrecognized contributing factors in the care that we deliver to our patients. And looking forward to things in 2017, I remain optimistic that we can continue our work on translational safety to take the things that we know from the literature and from our practices, from best practices, and actually turn them into action in our healthcare providers and in our communities to provide safer care, more effective care, and to reduce the harm that the healthcare system imparts on our patients. Thank you.
And Greg, thank you for inspiring us on this broader threat continuum that has brought into focus these relationships with Bill. And I know Inspector Vicki King, who has worn many hats in law enforcement, but I think just a very passionate, articulate brilliant woman that is standing in for Bill. Vicki, you're a close colleague of Bill. You all are doing spectacular things at Anderson. Your comments from what you heard today.
Well, I think that there's a common theme, and that is one of courage. It takes courage to look objectively at what we're trying to accomplish with the seminal goal of making a safer environment, not just for our patients, but also for the staff members, by reducing workplace violence and providing an avenue to prevent deaths. And MedTech certainly does that. It allows us to give everyone the best opportunity for survival in a critical situation. And looking at these important issues objectively, it's fascinating and so heartening to hear that we have so many courageous people on the front lines willing to put their time, attention, and intellect toward what has to be the highest goal, which is sustaining and preserving human life.
Well, thank you, Vicki, and thank you for the great work that you and Bill are doing. Carl, I see that Hillary Schmidt may have dropped off. And if she has, we have a short clip from Jennifer Dingman, who couldn't be on, and then we'll go to you, Arlene, for your comments and your closing.
I am on.
Oh, you are, Hillary. Oh, I couldn't see your name there. So Hillary Schmidt is, for my money, one of the global leaders in continuing education, and has taught us so much that we have implemented in our Care University and MedTech program in education, and really helping us understand how to have a powerful impact. We'll go a few minutes over, and we'd love to hear, Hillary, from what you heard today and insights that we can apply 2017.
Yeah, so I'll be really quick. I first of all want to thank everybody for the incredibly inspiring and innovative presentations of the work that you're doing to reduce error and prevent preventable mortality and patient harm. And as I listen to everybody, you're coming up with new ways of doing things, and it's going to require that individuals and as you know, I'm an expert in human learning, so I think about what does it take to actually translate this into action, as our last speaker was just discussing, and we're asking people to learn about new ways of thinking. We're asking them to develop new attitudes and develop core values, new ways of actually doing things, working with new processes, new tools like checklists, interacting in new ways, communicating differently with their team members, working as teams, working with new people as members of the team. So you're inviting patients to be part of it. MedTech's getting bystanders to be part of the first response and part of the solution to these problems. All of this is a really complicated learning task. We're asking individuals and teams and bystanders and leaders and systems to develop new ways of doing things. And they've got old habits, and we have to figure out ways to get them to develop new ways of doing things. And the MedTech approach, I want to also underscore, I think it was Jeanne was talking about, you need to inspire. The first thing you have to do is inspire people to come up with the inspiration to do things differently. And then you have to help them develop those skills. And the MedTech system is a beautiful way, with beautiful concepts in it of using simulation, using deliberate practice and feedback to help individuals and teams develop new ways of doing things. I always go back to the metaphor. Knowing how to do something doesn't mean that you can do it. And I'm learning tennis, and I can tell you how to serve a tennis ball. I can give you incredible detail on that. But can I show you how to serve a tennis ball? Less than 20% of the time. So knowing how is not translating into the ability to do. And we need to learn from the MedTech approach and the science of human learning how to ensure that all of this wonderful work is translated and into education that will be rapidly understood, remembered, and easily and fluidly and proficiently applied in the future as quickly as possible.
Thank you, Hillary. So articulate. We'll have you back in 2017 to help us with this translational issue of taking what we know to actually developing competency, and as Greg said, competency currency. I'd like to have Arlene Salamandra close on behalf of our patients, and I just want to ask Arlene to comment. She is a real expert at the front line in bullying in healthcare, a real champion for helping organizations take the high road, and that the bullying issue and abuse of power is the on-ramp for workplace violence, and we can see we have 5 times the amount in our sector. So Arlene, your comment, and then please close us, and if the speakers could just stay on for a minute, we'll do a rapid process improvement loop. Go ahead, Arlene.
Thank you, Jeff. Well, I work at a nursing home in a non-clinical frontline worker, and I love my job. I love the population. My coworkers and I worked together for a lot of years. We were team players. We all got along great, and we learned how to tolerate each other's shortcomings because we knew each other so well. Well, all of a sudden, leadership changed. The culture changed. Patient first became profit first. There was right away a huge turnover. People left. There were workplace injuries that were increased. And the last 2 years that I was there, I was bullied because I was still that patient advocate. I was still in the old mindset of putting the patient first. The residents were very unhappy, and they made their concerns known to me. When I made the concerns known to the administrator, I was harassed, I was picked on. They made my job miserable. I wrote a real heartfelt letter to the CEO, and that evening, after I wrote it, I was fired right after work. The administrator said I was no longer a team player. So I just want to let everybody know, if you treat your frontline workers well and you're all there for the patient first, leadership guides your culture. So it's very important that you have good leadership with the right goals. So thank you very much, Chuck, and thank you for the 100th webinar. And I want to thank everyone for joining us today. Have a good week, and please share what you learned with your colleagues. Thank you.
Thank you, and God bless you all, and thank you all for being such a great audience. And those that are watching that are not live, go back to the prior webinars of all of these superstar speakers who have done such a great job in 2017, 2016, 2015, and we will respond to your polls and give you what you are asking for in 2017. We're so grateful to have such terrific speakers. Thank you, and have a great month.